Disorders of the salivary glands. Salivary gland secretes saliva which lubricate mouth through small tubes called ducts. Normal health and function of oral structure depend on the normal structure and secretion of saliva by both minor and major salivary gland in a way that if one of them fails to supply the demand, the other group may compensate. One of the most important factor in diagnosis of disease is its composition and flow rate. Salivary gland. When there is a problem with the salivary glands or ducts, symptoms such as salivary gland swelling, dry mouth, pain, fever, and foul-tasting drainage into the mouth. The three major pairs of salivary glands are parotid glands on the insides of the cheeks, submandibular glands at the floor of the mouth, sublingual glands under the tongue. More than 800 minor salivary glands. Illustration of the major salivary glands: the parotid gland, the sublingual gland, and the submandibular gland, along with the facial nerve. Parotid gland. Present on either side of the mouth and in front of both ears. Largest salivary gland. Facial nerve divides it into two surgical zones, the superficial and deep lobes. Its Stenson's duct turn at right angle to reach oral cavity at the level of the second maxillary molar. Submandibular glands. Submandibular glands are a pair of walnut-sized glands located on each side of the face beneath and in front of the lower jaw at the back of the mouth. Also known as submaxillary glands. Lying superior to the digastric muscles, each submandibular gland is divided into superficial and deep lobes, which are separated by the mylohyoid muscle. The gland forms a C around the anterior margin of the mylohyoid muscle. Its Wharton's duct open lateral to the lingual frenulum. Sublingual salivary glands. Smallest of the major salivary glands. Located in the sublingual space. These almond-shaped structures are located under the floor of the mouth and below either side of the tongue. It drains directly into oral cavity by several small ducts or into submandibular duct through the Bartholin's duct. Diagnosis. 1. History. Duration. Onset. Nature and rate of growth. Pain. Evaluation of dry mouth. Radiation history. Past and present medical history. 2. Medical examination. Intraoral inspection and palpation for examination of ductal lesion, stone. Extraoral examination and palpation. Fluctuant in abscess. Firm, tense and not movable in infected and obstructed S.G. Firm and movable in benign tumors. Indurated and fixed in malignant tumors. 3. Diagnostic imaging. Conventional radiograph. Occlusal and oblique lateral for locating stones in submandibular S.G. PA and true lateral for stones in parotid gland. 2. Coelography. By injection RO contrast agent and take radiograph. 3. CT scan and MRI. 4. Laboratory investigation. CBC show increase in leukocyte. Smear for culture and sensitivity test. Biopsy. Smallest of the major salivary glands. Parotid glands. Submandibular glands. Sublingual glands. Thyroid glands. Smallest of the major salivary glands. Sublingual glands. Bartholin's duct is seen. Parotid glands. Submandibular glands. Sublingual glands. Thyroid glands. Bartholin's duct is seen. Sublingual glands. In parotid gland, facial nerve divides it into two surgical zones. This are the superficial and deep lobes. The superficial and anterior lobes. Deep lobes and anterior lobes. None of the above. In parotid gland, facial nerve divides it into two surgical zones. This are the superficial and deep lobes. Largest of the major salivary glands. Parotid glands. Submandibular glands. Sublingual glands. Thyroid glands. Largest of the major salivary glands. Parotid glands. In parotid glands, Stenson's duct turn at to reach oral cavity at the level of the second maxillary molar. Right angle. Left angle. Middle angle. All. In parotid glands, Stenson's duct turn at to reach oral cavity at the level of the second maxillary molar. Left angle. Stenson's duct is seen. Parotid glands. Submandibular glands. Sublingual glands. Thyroid glands. Stenson's duct is seen. Parotid glands. In parotid glands, Stenson's duct turn at right angle to reach oral cavity at the level of the fourth maxillary molar, the third maxillary molar, the second maxillary molar, the first maxillary molar. In parotid glands, Stenson's duct turn at right angle to reach oral cavity at the level of the second maxillary molar. In submandibular gland, Wharton's duct open. Middle to the lingual frenulum. Lateral to the lingual frenulum. Anterior to the lingual frenulum. Posterior to the lingual frenulum. In submandibular gland, Wharton's duct open. Lateral to the lingual frenulum. Wharton's duct is seen. Parotid glands. Submandibular glands. Sublingual glands. Thyroid glands. Wharton's duct is seen. Submandibular glands. Classification of salivary gland diseases. 1. Developmental abnormalities. Atresia, absence of the duct. Aplasia, absence of the gland. Aberrancy, ectopic gland. 2. Inflammatory and non-inflammatory swelling. 3. Cyst of salivary glands. 4. Salivary gland dysfunction. 5. Necrotizing sialametaplasia. 6. Tumors. 2. Inflammatory and non-inflammatory swelling. Sialadenitis. Salivary gland inflammation due to obstruction and infection of salivary gland by viral bacterial infection or allergic reaction. Signs and symptoms include pain, swelling of the gland, and fever. The most common microorganisms causing sialadenitis due to bacterial infections caused by Staphylococcus aureus, and among the virus most common is the mumps virus. Sialadenitis. Other virus are HIV, Coxsackie virus, parainfluenza types I and II, influenza A, and herpes. Other bacteria which can cause the infections include streptococci, coliforms, and various anaerobic bacteria. The parotid and submandibular glands are most commonly affected. Sialadenitis most commonly affects the elderly and chronically ill, especially those with dry mouth or who are dehydrated or who have salivary gland stones, but can also affect people of any age including newborn babies during the first few weeks after birth. Treatment includes antibiotics for bacterial infections, oral hydration, warm compresses, and sialagogues. Sialadenitis. It may be acute or chronic. For cases of refractory infection, surgical management, i.e., to drain abscess, may be indicated. Acute sialadenitis. A. Viral infection, mumps. Its most common viral infection affecting salivary gland caused by paramyxovirus and usually affecting both sides of the parotid gland. Clinical presentation: headache, myalgia, anorexia, malaise, mild fever, xerostomia followed by pain below the ear and sudden onset firm rubbery swelling of the gland. Acute sialadenitis. A. Viral infection, mumps. Diagnostic evaluation: leukocytopenia, increased serum amylase, viral serology antibodies. Treatment: it's self-limited disease. Fluid, anti-inflammatory to prevent secondary infection and analgesics. A. Viral infection, mumps. Complications: orchitis, testicular atrophy, and sterility 20% of young men. Meningitis in 10%. Oophoritis in 5%. Pancreatitis in 5%. Hearing loss 5%. Usually permanent. 80% acute sialadenitis. B. Acute bacterial sialadenitis. Salivary gland infection caused by Staph aureus and strep. Viridans. From the oral cavity by a reduction in salivary flow. Following major surgical operations. Due to dehydration. Poor oral hygiene. Other factors are drugs, antihistamine, antidepressant, diuretics, and tranquilizers. B. Acute bacterial sialadenitis. Clinical picture. Sudden onset. Gland is painful, enlarged at the angle of the mandible and tender. Warm and erythematous overlying skin. There is purulent discharge at its duct. It raises the lobule of the ear. Temp. Above 37.8 C. Acute sialadenitis. B. Acute bacterial sialadenitis. Treatment. -4 Antibiotic. Increase hydration and stimulation the saliva. Improve oral hygiene. If no improve, do surgical drainage by needle aspiration guided by CT or US. C. Chronic sialadenitis. This may follow acute infection of SG or may occur after pneumonia, papillary obstruction due to ill-fitting denture or duct stone causing inflammation and blockage of SG duct. The resultant sialadenitis produce stricture of the duct, stasis, dilation, stone formation, and chronic recurrent infection. Clinically, SG is firm, tender, and palpable bimanually. C. Chronic sialadenitis. Treatment. 1. Antibiotic. 2. Conservative treatment. 3. Surgical removal if no response. Acute non-suppurative sialadenitis is seen in acute bacterial sialadenitis. B. Mumps. C. Chronic bacterial sialadenitis. D. Necrotizing sialametaplasia. Acute non-suppurative sialadenitis is seen in B. Mumps. A 54-year-old woman come to your clinic complaining about a pain and swelling in the angle of the right submandibular region for 2 days. The patient had no previous history of facial trauma, carious teeth. What would be your diagnosis? Acute bacterial sialadenitis. Chronic bacterial sialadenitis. Acute viral sialadenitis. Chronic viral sialadenitis. A 54-year-old woman come to your clinic complaining about a pain and swelling in the angle of the right submandibular region for 2 days. The patient had no previous history of facial trauma, carious teeth. What would be your diagnosis? Acute bacterial sialadenitis. The most common complication of mumps is myocarditis. B. Orchitis. C. Uveitis. D. Conjunctivitis. The most common complication of mumps is B. Orchitis. A 35-year-old man come to your clinic complaining about a pain and swelling in the angle of the right submandibular region for 2 days. His temperature is 39 C and he had had pneumonia 15 days ago. What would be your diagnosis? Acute sialadenitis. Chronic sialadenitis. Both. A 35-year-old man come to your clinic complaining about a pain and swelling in the angle of the right submandibular region for 2 days. His temperature is 39 C and he had had pneumonia 15 days ago. What would be your diagnosis? Chronic sialadenitis. Which of the following statements are true about sialadenitis except the parotid and submandibular glands are most commonly affected? Most commonly affects the elderly and chronically ill person, especially those with dry mouth or who are dehydrated. It also affects newborn babies during the first few weeks after birth. It is always chronic. Which of the following statements are true about sialadenitis except it is always chronic? The most common microorganisms causing sialadenitis: Staphylococcus aureus. Mumps virus. Both. The most common microorganisms causing sialadenitis. Both. Most common virus that cause sialadenitis is mumps, influenza A, herpes, HIV. Most common virus that cause sialadenitis is mumps. The most common bacteria that cause sialadenitis is mumps virus, Staphylococcus aureus, Streptococci, coliforms. The most common bacteria that cause sialadenitis is Staphylococcus aureus. Which virus cause acute sialadenitis? Paramyxovirus, influenza A, herpes, HIV. Which virus cause acute sialadenitis? Paramyxovirus. Viral infection of acute sialadenitis may lead to which of the complication except orchitis, meningitis, oophoриtis, pancreatitis, bilateral hearing loss. Viral infection of acute sialadenitis may lead to which of the complication except bilateral hearing loss. Acute bacterial sialadenitis is caused by Staph aureus, Strept, viridans. Both. None of the above. Acute bacterial sialadenitis is caused by both. Sialolithiasis, salivary stones. It's the formation of the salivary stone in the gland or its duct resulting in the obstruction of the salivary flow. The most common cause of swollen salivary glands, salivary stones are buildups of crystallized saliva deposits. Submandibular gland most common. Sialolithiasis, salivary stones. Clinical feature: pain and swelling during and after eating. Xerostomia. Stone can palpated at examination, especially if it's present at peripheral aspect of the duct. Diagnostics: radiograph plain occlusal film. Sialography demonstrate the lumen of the ducts for stone. Sialolithiasis, salivary stones. Treatment: surgical removal of the stone. If its removal cause extreme damage to the gland, may indicate excision of the gland. Salivary gland stone most commonly involves A. Submandibular gland, B. Parotid gland, C. Sublingual glands, D. Lingual glands. Salivary gland stone most commonly involves A. Submandibular gland. Sialadenosis. It's non-inflammatory non-neoplastic swelling of the SG. The enlargement are painless and bilateral, usually, more common in women. It's occur in the following condition: hormonal disorder, autoimmune disorder, DM, HIV, liver cirrhosis, kidney pancreas, malnutrition, Sjogren's syndrome. This condition consists of dry mouth, dry eye and rheumatoid arthritis. Patient complain from xerostomia, burning sensation, ulceration on the oral and conjunctival mucosa. Diagnosis: biopsy of salivary gland, lower lip. Lab test: rheumatoid factor ESR, anti-nuclear antibody. Sialogram demonstrate the cavity defect filled with radiopaque contrast media, branchless fruit-laden tree. Sjogren's syndrome. Treatment: treat recurrent infection. Salivary substitute/sprays. Cholinergic drugs, pilocarpine. Avoid alcohol, tobacco. Immunosuppressive, corticosteroids or cytotoxic. Leafless fruit-laden tree or cherry blossom appearance on a sialogram indicates mucoepidermoid cell carcinoma, B. acinar cell carcinoma, C. Sjogren's syndrome, D. pleomorphic adenoma. Leafless fruit-laden tree or cherry blossom appearance on a sialogram indicates C. Sjogren's syndrome. Sjogren's syndrome includes all except xerostomia, B. keratoconjunctivitis, C. arthritis, D. lymphoma. Sjogren's syndrome includes all except D. lymphoma. Which of the following statements about Sjogren's syndrome is incorrect? MRI shows salt and pepper appearance. B. Lacrimal gland enlargement is common. C. Minor salivary gland biopsy is a diagnostic test. D. Pilocarpine is the most useful and convenient drug in its treatment. Which of the following statements about Sjogren's syndrome is incorrect? B. Lacrimal gland enlargement is common. Sjogren's syndrome affects A. Exocrine glands, B. paracrine glands, C. endocrine glands, D. autocrine glands. Sjogren's syndrome affects A. Exocrine glands. 3. Cyst of salivary glands. Mucocele. Swelling due to accumulation of saliva as a result to trauma or obstruction to the duct. Extravasation cyst caused by trauma bite the lip or cheek result in accumulation of mucin in. Retention cyst caused by obstruction by stone, tumor, or scar. 3. Cyst of salivary glands. Mucocele. Clinical appearance. Painless swelling. If it superficially appear bluish translucent and fluctuant or cover by normal mucosa and it's firm. Treatment by surgical excision. Mucocele most commonly arise as a result of rupture of a salivary gland. B. Partial or complete compression of the salivary acini. C. Inflammatory changes in the glandular interstitial tissue. D. Partial or complete obstruction of the salivary duct by calculus. Mucocele most commonly arise as a result of rupture of a salivary gland. Ranula. Special type of mucocele in the floor of the mouth. Associated with ducts from the submandibular or sublingual gland. Start as painless swelling. Translucent blue color in appearance. Can cause elevation of the tongue. Ranula. Slow enlarging swelling on the floor of the mouth can cause difficulty in speech or eating. When deep lesion herniates through mylohyoid muscle and extend along the facial planes, it is referred plunging ranula. Investigation by aspiration biopsy. Treatment, marsupialization. A cyst occurs under the tongue, caused by obstruction of a salivary gland. Such a cyst is called mucocele. B. Ranula. C. Dermoid cyst. D. Dentigerous cyst. A cyst occurs under the tongue, caused by obstruction of a salivary gland. Such a cyst is called B. Ranula. 4. Salivary gland dysfunction. Xerostomia. Its sensation of dry mouth because of decrease of glandular secretion due to aging, duct obstruction, medication, radiation therapy, smoking, Sjogren's syndrome. Treatment. Conservative treatment and maintain oral hygiene. Use artificial saliva and sialagogues as pilocarpine. A condition of the mouth which increases the caries activity in the oral cavity is xerostomia. B. Malignancy. C. Hairy tongue. D. Watery saliva. A condition of the mouth which increases the caries activity in the oral cavity is xerostomia. Reduction in flow of saliva is not generally seen in elderly diabetics. B. Patient undergoing radiation therapy. C. Patients suffering from Parkinsonism. D. Patients on phenothiazine drugs. Reduction in flow of saliva is not generally seen in C. Patients suffering from Parkinsonism. Xerostomia is seen in all of the following except anticholinergic drugs. B. Dehydration. C. Sjogren's syndrome. D. Oral sepsis. Xerostomia is seen in all of the following except D. Oral sepsis. 4. Salivary gland dysfunction. Sialorrhea, tylism. It's excessive salivation. It may be mild, intermittent, or continuous drooling. This condition may be due to irritation from ill-fitting denture or heavy metal poisoning, mental retardation, medication, cholinergic agonist. Treatment by physical therapy and anticholinergic atropine. 5. Necrotizing sialametaplasia. Non-neoplastic inflammatory lesion of unknown etiology of minor salivary gland tissue, which both clinically and histologically mimics a salivary gland malignancy. Trauma lead to ischemia, acinar necrosis, and squamous metaplasia of the duct. The lesion generally presents as an ulcer. Seen posterior in hard palate. 5. Necrotizing sialometaplasia. Investigation, biopsy. Treatment. Irrigation by hydrogen peroxide or saline itself limited and healing by secondary intention. The common site for necrotizing sialometaplasia is cheeks, dorsum of tongue, C. palate, D. gingiva. The common site for necrotizing sialometaplasia is C. palate. A painful crater-like 1.5 cm ulcer develops within 1 week on the hard palate mucosa of a 40-year-old female. The most likely diagnosis is actinomycosis, B. squamous cell carcinoma, C. pleomorphic adenoma, D. necrotizing sialometaplasia. A painful crater-like 1.5 cm ulcer develops within 1 week on the hard palate mucosa of a 40-year-old female. The most likely diagnosis is D. necrotizing sialometaplasia. Benign tumors of salivary gland. Pleomorphic adenoma. Also called benign mixed tumor. Most common salivary neoplasm can involve any major or minor salivary gland. Clinical feature. Slow growing. Painless. Firm non-tender. Mobile in early stages with increases in size irregular and nodular upon palpation. Intermittent growth period. Pleomorphic adenoma. Treatment. The treatment for salivary gland tumor is surgical resection. Benign tumors of the parotid gland are treated with superficial or total parotidectomy. Pleomorphic adenoma arises from myoepithelial cells, B. acinar cells, C. connective tissue, D. stem cells. Pleomorphic adenoma arises from myoepithelial cells. Most common tumor of salivary gland is pleomorphic adenoma, B. adenoid cystic carcinoma, C. cylindrioma, D. epidermoid carcinoma. Most common tumor of salivary gland is pleomorphic adenoma. The recurrence of pleomorphic adenoma is attributed to presence of an incomplete capsule, B. mixed origin, C. absence of capsule, D. perineural spread. The recurrence of pleomorphic adenoma is attributed to presence of an incomplete capsule. Mixed tumors of the salivary glands are most common in submandibular gland, B. usually malignant, C. most common in the parotid gland, D. associated with calculi. Mixed tumors of the salivary glands are C. most common in the parotid gland. Pleomorphic adenoma is a teratomatous tumor of the salivary gland, B. a neuroendocrine cell tumor, C. multiple ectopic tissue proliferating in the salivary gland, D. myoepithelial or ductal reserve cell origin. Pleomorphic adenoma is D. myoepithelial or ductal reserve cell origin. Benign tumors of salivary gland. Warthin's tumor. Slowly growing benign tumor of the parotid gland. The tumor is firm, non-tender, painless, and usually appears in the tail of the parotid gland near the angle of the mandible. Painless until superinfected. Warthin's tumor. Investigation. Biopsy. MRI. CTS. Sialogram show displacement of glandular tissue. Treatment by surgical excision. Warthin's tumor is an adenolymphoma of the parotid gland, B. a pleomorphic adenoma of the salivary gland, C. carcinoma of the parotid gland, D. none of the above. Warthin's tumor is an adenolymphoma of the parotid gland. Which tumor does not occur in minor salivary gland? Pleomorphic adenoma. B. adenocarcinoma. C. mucoepidermoid carcinoma. D. Warthin's tumor. Which tumor does not occur in minor salivary gland? D. Warthin's tumor. Adenolymphoma refers to adenocarcinoma. B. adenocystic lymphoma. C. Warthin's tumor. D. Pleomorphic adenoma. Adenolymphoma refers to C. Warthin's tumor. A salivary gland tumor, which histologically shows a double layer of epithelial cells based on a reactive lymphoid stroma is pleomorphic adenoma. B. Mucoepidermoid carcinoma. C. Acinic cell tumor. D. Warthin tumor. A salivary gland tumor, which histologically shows a double layer of epithelial cells based on a reactive lymphoid stroma is D. Warthin tumor. Malignant tumors. Mucoepidermoid carcinoma. Most common type of malignant salivary gland tumor. Clinical feature. Mostly affected parotid gland. Presents as painless unless infection or invasion of vital structure, slow-growing mass that is firm or hard not movable. Some tumors grow rapidly. Metastasis is seen in high-grade tumor. Poor prognosis. Mucoepidermoid carcinoma. Treatment. Surgical excision. Radiotherapy should be added to improve local control. Most common salivary gland malignant neoplasm in bones is pleomorphic adenoma. B. Adenoid cystic carcinoma. C. Mucoepidermoid carcinoma. D. Adenolymphoma. Most common salivary gland malignant neoplasm in bones is C. Mucoepidermoid carcinoma. Commonest salivary gland tumor in children. Lymphoma. B. Pleomorphic adenoma. C. Adenoid cystic carcinoma. D. Mucoepidermoid carcinoma. Commonest salivary gland tumor in children. D. Mucoepidermoid carcinoma. In which of the following salivary gland tumors, the tumor is composed of intermediate cells histologically? Adenoid cystic carcinoma. B. Mucoepidermoid carcinoma. C. Pleomorphic adenoma. D. Warthin's tumor. In which of the following salivary gland tumors, the tumor is composed of intermediate cells histologically? B. Mucoepidermoid carcinoma. Adenoid cystic carcinoma. Rare type of cancer that can exist in many different body sites. It most often occurs in the areas of the head and neck, in particular the salivary glands. Patients may survive for years with metastases because this tumor is generally well differentiated and slow growing. It is the second most common malignant salivary gland tumor overall, after mucoepidermoid carcinoma. Malignant tumors. Adenoid cystic carcinoma. Treatment. Primary treatment: surgical removal with clean margins. Palliative radiotherapy is commonly given following surgery. Which of the following parotid malignancy shows perineuronal spread? Pleomorphic adenoma. B. Adenoid cystic carcinoma. C. Warthin's tumor. D. Ductal papilloma. Which of the following parotid malignancy shows perineuronal spread? B. Adenoid cystic carcinoma. Adenoid cystic carcinoma is also known as A. cylindroma. B. Pindborg tumor. C. Warthin's tumor. D. Pleomorphic adenoma. Adenoid cystic carcinoma is also known as A. cylindroma. Cribriform, honeycomb or Swiss cheese histology pattern is seen in adenoid cystic carcinoma. B. Pleomorphic adenoma. C. Acinic cell carcinoma. D. clear cell carcinoma. Cribriform, honeycomb or Swiss cheese histology pattern is seen in adenoid cystic carcinoma.